Thank you, and hi everyone. Excuse me. I'm actually just getting over a bout of a pericarditis secondary to a nasty little virus that I had. So excuse me if I've got a bit of a cough and periodically I wince as I anyway, long story. Rather not go back to it. It's interesting to see as well, Jonathan, Professor Kavanagh there, who was my supervisor way back in the day when I was a foundation year doctor in the academic foundation program. So hello, long time no see. I guess.
Great to see you.
Okay. So I suppose from my point of view in this little talk, I just wanted to briefly kind of introduce you to some concepts from a child and adolescent point of view, in particular in neurodevelopment. So that's the area which I am particularly interested in. I think I might be, as well, as far as I know, I'm the only openly autistic child and adolescent psychiatrist in Scotland that I'm aware of, unless anybody knows. Anyone else can correct me on that, but as far as I know, that's the case. And maybe unsurprisingly, therefore, my interest particularly is around neurodevelopmental conditions in children. And by that, I guess we mean the whole gambit of developmental conditions that might affect somebody's mental health. So that would be things like autism, ADHD, learning disability, not to be confused with learning difficulties, and other developmental conditions. Developmental coordination disorders, specific language disorders, a huge gambit of our kind of smaller print kind of conditions, which often coexist and often sit within, I guess, under an umbrella of neurodiversity, as we might call it now. So we're moving away from this individualized individual diagnosis, and we're moving into thinking about kids in the whole, or trying to think about kids in the whole. And I guess I haven't written it in here, but if you're interested in that, you might want to look at a concept called ESSENCE, E-S-S-E-N-C-E, and in particular, Professor Chris Gilberg, who is the kind of pioneer around that area of multi-morbidity in this group of children, essentially. So basically, seldom do neurodevelopmental conditions come alone. You often have a mix of more than one. And that can mean, particularly when you're working with young kids, and probably it's the case for general adult as well, in terms of dealing with people with neurodevelopmental conditions, verbal communication sometimes is not always that easy. So these kids are not going to sit and talk to you as much as your average child might do. You might spend a lot of time in silence. Often, classically, when these kids come in to meet you, if you're going to try and do an assessment or work out what's causing their difficulties or what they're finding hard, your first 4 or 5 sessions are simply building trust, and often their first place will be, behind the table, behind the chair. So you need to resort to behavioural techniques, and I guess this is the kind of aspect of my talk, which for me is really important, and that is to understand and think about behaviour. And actually, Professor Kavanagh started off by talking a lot about behaviour and the behavioural manifestations of mental illness, and I think the same is true within neurodevelopmental conditions. So we need to think about play. I've used loads of things. We use Lego. You might use fleecy blankets as play ropes and things like that, just to break ice and to get things going. Observation, and most importantly, I would say curiosity. So lesson 1, here's the thing that used to bug me when I was an SHO in psychiatry. I don't know what it's like now, but a lot of the time people would conflate the words with behaviour, and they would conflate that with somebody was at it, they weren't really unwell. So nurses would come up to you and they would say, it's all behavioural. This guy's all behavioural. I've seen him before, he's been in, this guy's in all the time, it's all behavioural. And I used to look at them a bit confused and think, well, yeah, because all behaviour is behavioural, isn't it? So obviously it's behavioural, and therefore all mental illness is ultimately behavioural, because the manifestations that we are seeing are manifestations of behaviour caused by the mental, the manifestations of that illness within the brain, or that condition within the brain. So lesson one for me is all behaviour is behavioural, and as soon as somebody says that's behavioural, you need to just slap them down. You have to be right away there when if you're going into psychiatry and say, of course it's behavioural, you know, because everything's behavioural. Us sitting around here now having this chat is behavioural. Lesson two for me is that all behaviour has a purpose. So we don't tend to do things as human beings for no reason. Now, I'm sure that people can throw up some aspects here and say, you know, there's exceptions here. I'm sure there are, but generally speaking, behaviour is reward driven, or at the very least, it serves a function of some description to the individual. So there's a purpose behind behaviour, and our job, I would argue, is to look for that purpose, to understand it, even if in the first instance you don't know what that purpose is, what the function of that behaviour is. It is likely that it serves a function, even if the individual themselves don't know what that function is. That's that concept of insight. So if you think about behaviour and you think about what you're observing, for me, I think the next thing is to think, this behaviour in this individual has a purpose. What is it? Be curious. That's back to that aspect of curiosity before. And taking that on the next step then, all behaviour is communication. So somebody communicates, most of what they communicate is done through body language, through behaviour, through, you know, their presentation, rather than through what they say. And particularly that's important in children who can't or won't speak. So if they're not going to engage with you verbally, then one of the most important things to note is to watch communication and see what is being communicated, if you like, through behaviour. So it doesn't mean that these kids don't communicate. They do. They communicate very well, actually. But you'll miss it if you don't have a curious approach, if you don't sit and say, wonder why he does that. Wonder why do you think he goes into the, you know, he whatever it is, runs out the classroom, or why do you think he pulls off the, you know, pulled the radiator off the wall? These are the kind of things that we generally get referred to. You know, why do you think he does that? What do you think the reason for that is? And often that's what's missing before these kids are referred to us. Lesson 4 for me, therefore, is curiosity, curiosity, curiosity. If you're coming in to deal with children, you're going to come in and think about children from a neurodevelopmental point of view, and I guess this applies for adults as well, then they're all individuals. There's no purpose in trying to use a generic application. You need to be curious about why, what, where, when, why, how. Why are they doing what they're doing? What does that mean? What does that mean? What are they communicating to you? Because they'll be communicating something. You just have to work out what it is. And I guess the other thing is you need to be careful not to be presumptuous. So again, going back to those long nights on the adult wards as a duty doctor, don't presume that you know what behaviour means or why somebody is doing something. You mustn't presume that you know. Because 99 times out of 100, I would argue, you're probably going to be wrong. So my lesson 5, thinking about kids with neurodevelopmental conditions in particular, but applying that to any aspect of psychiatry, and in fact, it applies to any aspect of medicine, to be honest, is that you need to understand the individual in front of you. And the best way to do that is to think formulation before you think diagnosis. So that's my message, think formulation. What's going on? Be child-centered. You know, think about the child holistically. I've said there, use a wide-angle lens. I'm a photographer, and I quite like that aspect of wide-angled lenses. So rather than a kind of telephoto, really narrow view, you're looking at the wide angle. What's happening in the family? What's happening at school? What's their experience like? What's it like to be this guy or this girl? What difficulties do they face? Trying to put yourself in their position, trying to use that mentalization approach. And using that with a bit of playfulness, with acceptance, or pace is one of the things that we often apply as a kind of concept. Acceptance, it is what it is. Curiosity, why? What's the deal? What's that about? And empathy, can I kind of understand what it is that they're doing? Can I understand what it's like to be this person? And then maybe you've got some aspect of, you know, understanding of what their behaviour is about and what they're trying to tell you. Without that approach, you'll miss huge amounts within psychiatry. That would be my argument. So I think with that, I'm probably finished. No idea if I'm on time because I've got no clock to watch, but hopefully I'm not too far off.